Hello, my name is Irene Gabriel. I'm a professor of medicine at Dana-Farber Cancer Institute in Boston, and I will be talking today about biological implications of molecular studies in multiple myeloma and precursor disorders, early detection of disease of unique populations. So just to remind everyone that every single cancer, by the time the patients are diagnosed with symptomatic disease, they may have had years and years of an early progression from a normal cell to a precursor cell, in some cases a polyp like in colon cancer, an early lesion as in prostate cancer or breast cancer, and then finally the patients are symptomatic or they have the disease. And it's the same for multiple myeloma. In fact, we are lucky in hematological malignancies, both multiple myeloma and CLL, as well as the new entity of CHIP, clonal hematopoiesis of indeterminate potential, because we can diagnose those patients early from a blood sample. And in the case of MGUS, we've been lucky to have a biomarker of this early precursor condition with a monoclonal protein for the last 40, 50 years. And we understand exactly how those patients progress from an early MGUS stage to overt myeloma. The other important factor to know about is that every single patient today, when they come in with symptomatic myeloma, when they have the bone pain, when they have the anemia, they may have had this precursor MGUS and smoldering myeloma for years, and it went undetected because we do not screen for it and we do not look for it. Now, if we think about the rate of progression of MGUS and smoldering myeloma, we may actually say, well, it's fine because MGUS rate of progression is only 1% per year, and many patients may actually have another competing cause of death. However, for smoldering myeloma, the case is very different. Now the rate of progression is 10% per year. And in many patients, the high-risk smoldering myeloma, the rate of progression is 50% in 2 years. And the question is truly, when you see someone today who was incidentally diagnosed with MGUS or with smoldering myeloma, especially with high-risk smoldering myeloma, would you tell them, let's continue on watch and wait, or would you consider some risk stratification to decide on early therapeutic potential for those patients to prevent progression and to prevent end organ damage? Now, the first thing that happened recently is that the IMWG has changed the criteria so that now instead of treating patients with CRAB criteria only, we have now added the 60% plasma cells, the light chain ratio of over 100, and the lesions by MRI or PET-CT scan. That already tells us that we are moving towards treating patients before they have end organ damage and before they have symptomatic disease. However, that may not be enough. And indeed, we still have this entity of smoldering myeloma. We still have patients who are not MGUS, who are not early precursor with a 1% per year rate of progression, and who are not overt myeloma based on this criteria. And the question is, how do you define those smoldering myeloma patients? How do you define who is truly high risk? And who do you define as a therapeutic entity patient, someone that you think I should consider a clinical trial or therapy for this patient? Now, there has been multiple models for many years in the past, the Mayo Clinic model, the Spanish model, evolving criteria. And most recently, the IMWG showed us that 2020, which is 2 grams of M-spike, 20% plasma cells in the bone marrow, and 20 light chain ratio can differentiate patients between high risk, intermediate, and low risk. And if any of the patients have 2 factors, they would be considered high risk by this model system. And indeed, that model took in effect all of the prior data and looked at high risk cytogenetic, looked at evolving M-spike, and also made sure that they exclude the myeloma defining events, the new criteria that we have for multiple myeloma. So indeed, this is a new interesting clinical model that we can use to date with our patients. Now, if you add the cytogenetics to this model, indeed, you can see that it improves from 40, 50% risk of progression at 2 years to a much better way of thinking of those patients, up to 60% and 70% in cases when you have multiple cytogenetic abnormality. So it improves on your risk stratification in those patients. And I think that's the one point to remember, it's improving on the risk stratification. And I would say that there were a couple of problems that we faced when we started looking at 2220. One, it's only one time point. And the question is, what do you do with dynamic evolution? What do you do with your patients that you follow them every 3 months, every 6 months, the ones who are progressing, or the ones who tell you, I'm 2220, but I've been stable for the last 15 years. Do you want to treat me now? So we have to think of a patient as a true rate of progression, as a true dynamic evolution, including the clinical markers, but also including other factors. And to try and ask those big questions, to try and understand truly who will progress in their lifetime and who is at risk of developing disease and who should be treated, we developed a new center called the Center for Prevention of Progression at Dana-Farber. And we decided that instead of looking at patients when they have symptomatic disease, we're going to focus on the asymptomatic, on the early precursor conditions. And we will not only look at multiple myeloma, but we're looking at CLL and at CHIP mutations, and having all of us work together in hematological malignancies to look at patients with CHIP or MGUS or MBL, and potentially even have a multidisciplinary approach, because CHIP mutations lead to cardiovascular diseases. So we have a cardiologist as part of it. We have a genetic counselor as part of it. And it's truly a holistic approach to early precursor conditions. And the next question we had is, well, if you have to see patients at Dana-Farber in Boston, that excludes many patients who are truly all over the world and potentially would want to benefit from this. So we created a new study that's truly, I think, a patient empowering study called PCrowd. And it's precursor and then crowdsourcing, but instead of crowdsourcing for patients, we're crowdsourcing for, or instead of crowdsourcing for money, we're crowdsourcing for patients. We truly want every single patient to be part of this community, to be part of this research, so that we can answer big questions when we have big numbers of patients. And PCrowd is online. Any patient can go on it and sign up. They do not need a physician to consent. So we've taken away those limitations that we have for patients to be part of research. And they can give us their blood sample or their bone marrow sample wherever they live in the United States and potentially now all over the world. And by doing that, we have 3,000 patients who are being followed over the years. And this is that power of being able to ask big questions, to ask who will progress in their lifetime and who will not. Now, when we started that and we had all those patients, a lot of them will ask me, well, I was diagnosed incidentally. This was pure luck that I was found to have MGUS. This was pure luck that my doctor decided to check my monoclonal protein. And we asked another question: why are we not screening for multiple myeloma? If we know that myeloma is still incurable, if we know that if we potentially treat early at the smoldering stage, we can improve survival, then why are we not screening for smoldering myeloma and MGUS and amyloidosis? Why is it that a blood sample could be not tested for a monoclonal protein, which is very simple and very cheap, while we're doing cancer screening for many other cancers with many more invasive procedures, mammography, colonoscopy? And I would say that I would rather have a blood test than have any of those invasive procedures. And we know that cancer screening saves lives. So truly the question is, can we develop a cancer screening study for multiple myeloma, and with that make a difference for early detection and potentially early interception for our patients? And this was the concept of the PROMISE study. The PROMISE study is truly also a nationwide study that asks the question, who are those people who are at risk for myeloma, and can we identify them early and prevent progression? Now, PROMISE is recruiting 30,000 individuals who are at risk for myeloma. And these are either patients who are of African descent, African American, Black American, or people who have a first-degree relative of someone with myeloma or lymphoma or Waldenstrom. And with that, we're trying to recruit 30,000 people so that we can get 3,000 positive cases. Now, you would think that that's a very high percentage. 10% of the population that we screen will be positive. And the answer is that's based on already our own data of the first 1,500. When we screened them by mass spectrometry in collaboration with Mayo Clinic, we found that our screening indicates that we're almost at 10% and not at 3 or 4% as we expect in the regular population with MGUS. So already we know that this high-risk population has a high rate of potentially being positive. And then we're taking this 3,000 positive cohort and asking big questions. What are the genomic and epigenetic markers that lead to progression? What is the immune microenvironment and how that regulates and allows the progression of patients to multiple myeloma? And can you use that to prevent it by developing immunotherapy? What are the new targets that we can develop, bone imaging modalities, therapeutic targets that we can bring in those patients at an early time point? The other thing that we wanted to make sure of is we wanted to make sure that our recruitment for Black Americans is as high as it should be. And we set a goal of 20%. And indeed, now we have about 16% recruitment, and we're hoping to increase it up to 20%. We're hoping to really be the first study that really focuses on disparity, on truly allowing Black Americans to be part of this research for early detection, for early prevention, and potentially, can we change the survival? Can we improve on the survival of our patients by this method of treatment? Now, for us to get 30,000 individuals, it really takes a lot of effort. And I can tell you, it has been really challenging and interesting, but challenging for the last 2 years for me to learn not to be a scientist or a clinician, but to learn how to recruit, how to get social media events, how to do on the ground work, how to tell our healthy or our healthy individuals that they should screen for this and be part of this initiative. And we've done many initiatives, including virtual, mailing, and on the ground. And of course, on the ground was a lot of work in churches, in barber shops, in health fairs. And you can see even we worked with our congresswomen and men, including Ayanna Pressley here from Massachusetts. But that was really all before we started having the COVID-19. And post-COVID-19, we found that indeed we have a problem here that we would love to actually change the way we think. And because we were all confined and we couldn't figure out what to do, we started a new initiative called Impact. And Impact is truly changing the way of taking patients who are on PROMISE and PCrowd and asking more questions. What is the effect of COVID-19 on our own precursor patients? What will happen for those patients if they get infected with COVID-19? What will happen with those patients if they get the vaccination? Will their immune system work or not? We have many studies on cancer patients, multiple myeloma patients, and we know that their prognosis may be worse if they get infected. And we have studies on normal, healthy individuals, but the people who are in the precursor, the MGUS and smoldering, who are in between, they don't know what their immune system looks like and whether they are at risk for COVID-19 more than the general population and whether they should be prioritized for vaccinations or not. So Impact, which will launch hopefully in the next few weeks, is truly about trying to empower our own patients to understand their own immune system. We will be giving them a free Quest diagnostic test. And that test will allow them to know if they have an antibody to COVID-19 or not. So this is not the PCR for the virus. This is an antibody test. And then we're checking their immune cells by doing single cell RNA sequencing at different time points for the next 1 year to understand truly what will happen to them if they get infected, but more importantly, if they get the vaccination. Now, to also understand better clonal evolution and taking all of those samples from the PCrowd and PROMISE study and ask the question, what is the mechanism of clonal evolution in smoldering myeloma? This is a study that we just published in JCO recently, where we took 214 patients and asked the question of next generation sequencing in smoldering. Of those, 85 people were not treated on any clinical trials, and they had over 5 years of follow-up for progression to myeloma. So we have the progressors and the non-progressors, as you can see here. And you can immediately see that the progressors had a lot of single nucleotide variants, MAP kinase mutation, many mutations, much more common compared to the silent group, which is the other group that were non-progressors. Now, when you start looking more carefully at the mutations or alterations that were associated with significant risk of progression, we found 3 markers that truly can predict progression. MYC alterations, so these are translocations or amplification, MAP kinase mutations, KRAS and RAS and BRAF, as well as DNA repair mutations, P53, ATM, ATR. And these were independent of the clinical markers at significantly high risk of progression. But even if you add them to the clinical markers, even if you add them to 2220, now your progression improves the stratification of those patients from 50% at 2 years to 70, 80% at 2 years. I would like to have that precision in my risk stratification for my patients, and they would appreciate to know in a much stronger way whether they will truly progress in their lifetime. So here you can see that if you have the data of genomic aberrations, one of those 3, compared to not having it, you have a huge difference in your median progression-free survival from 1.1 years to 3.6 years. So again, this gives you that increased stratification for your patients. Now, the last part is asking, what is the role of the immune microenvironment? So we know that genomic clonal evolution is important, that there is this constant clonal evolution and progression of the clones, but is that allowed by the permissive microenvironment? Is the immune system allowing progression or not? And we did that also in another paper, again from the PCrowd study, where we found that if you do single cell RNA sequencing on the immune cells of patients, healthy control, MGUS, smoldering, and multiple myeloma, you find that indeed the immune microenvironment has an abundant number of T cells and NK cells within the microenvironment. But interestingly, the composition of those immune cells changes significantly when you move from healthy to MGUS to myeloma. So as you can see here on the right side, when you move from blue to red, suddenly now you're going with a change in the composition of T cells, CD16 monocytes, and some of the NK cells, indicating that even as early as MGUS, you're starting to have compositional changes, but they gradually get worse as you get to multiple myeloma. And I'll give you two examples. This is the NK cells, and you can see that there were two markers that indicated changes in the NK cells, CXCR4 and CX3CR1. CXCR4 is important for keeping the cells, the NK cells, within the microenvironment because it is important for homing and migration. And CX3CR1 allows them to egress. And you can see that the patients who had a high CXCR4 had more NK cells present within the microenvironment, allowing them to interact with the tumor cells. And although they may not be the efficient NK cells, but they were directly interacting there. So the future studies will be not only to look at the compositional changes of NK cells, but also where they are located and how do they interact with the tumor cells. The other example is the T cells. We found several subclusters of T cells. And most interestingly, you can see here on your right side is that in the orange line, these were the memory cytotoxic T cells. And as you go from a normal bone marrow to MGUS, to smoldering myeloma, to overt myeloma, you're constantly losing your memory cytotoxic T cells. And that's a sign of progression, that indeed, potentially, if we target memory cytotoxic T cells and allow them to be sustained, that may actually prevent progression of multiple myeloma. And this is an important step for us to understand how to modulate the immune system to prevent progression, but also what are the markers that lead to that progression in those patients. And we found a similar story with T regulatory cells, where we found a high level of Tregs going up as you progress to multiple myeloma. So in summary, this shows you that as early as MGUS, we have immune changes. When people say MGUS is normal, it is not. The immune system already changed in the MGUS setting with compositional changes in NK cells, CD16 monocytes, Tregs, and then you have further changes, including memory CD8 T cell depletion as you progress to myeloma, and then interferon alpha response changing in those patients, again, as you progress to multiple myeloma. And potentially that gives us that benefit of understanding when to intervene, but also can we use those as biomarkers of progression in our patients from MGUS to smoldering to myeloma. Now, the last step is, what do we do with that? We know that currently there are 2 phase 3 trials that showed us that you can improve on progression-free survival when you use lenalidomide and dexamethasone. So already there is data that immunotherapy with lenalidomide can make a difference. And I hope that what we do in smoldering myeloma is, instead of repeating the same things that we've done with myeloma, just giving them the same conventional therapy, let's think of precision interception. Let's think of a new way of thinking, genomically marking them, understanding their immune microenvironment, and then tailoring the therapy based on their own genomic and immune microenvironment, tailoring their therapy based on their own risk stratification, whether they're truly high risk or not, and bringing it to the next level. Instead of doing the same attempts we've done in myeloma, which were wonderful and have changed our survival, let's leap into the future and develop precision interception for our patients with smoldering myeloma so that potentially we can cure this disease by early intervention. So with that, I'd like to thank you. I'd like to thank, of course, my lab and clinical teams, my collaborators, especially Gary Getz, Tim Rabbit, Catherine Marinak, and many others, and of course, our funding from Stand Up to Cancer, NIH, MMRF, Leukemia Lymphoma Society, and above all, our patients. Thank you.